Pam, how is it going over at Santa Monica? Are you ready to get started?
We are ready and excited.
All right. Well, welcome everybody to round 2 of the Rapid Fire Grand Rounds. We will start with a little bit of housekeeping. So after the session, we're going to give everybody an opportunity to complete online evaluation forms. They can be found at this link. We do have a few iPads here that will log in or help you log in directly to the survey. If for whatever reason you're unable to complete the survey right at the end of this session, we will be sending out an email to the email that you put on the sign-in sheets. So please make sure if you're going to leave, we do have your email so you can do your evaluation. The evaluation is a 2-part form. The first part is confidential. That's where we want you to give us the feedback. And the second part is tied to your CE. So we'll just ask you to enter your name, and that way we can get you the BRN CE. Any questions on evaluations? All right. So nurses leading change. That is really the topic of today's Rapid Fire Grand Rounds. We have 5 examples of nurses leading change. And I just want to highlight the IOM report. Who here is familiar with the IOM report, The Future of Nursing, Leading Change, and Advancing Health? All right, the majority of the people here. And so basically within the report it says that the U.S. healthcare system is in need of reform. And who are the ones to do it? It's nurses. We're the largest healthcare workforce that there is. And so if we want to transform practice, it's now to speak up and have a voice and start projects that'll really make a difference, whether at the unit level or organizational level or even the national level. And so all of these projects that you're hearing today are just that, examples of nurses leading change. So with that, I'm going to introduce our first presenter.
I was just going to point out too that part of the report says not only about us leading change, but really also partnering in change. And I think we're going to see that today as we have some OT colleagues here who are partners in leading a really successful project. So very important for us to not only see ourselves as leaders, but also as great partners.
Very good point. Did you hear that, Santa Monica?
No, we did not.
It was said so eloquently, I'm going to have Lee say it again.
Hello, Santa Monica. It's Lee. I was just saying that, that in the report it highlighted not only the role of nurses leading change, but really also said that nurses would be great partners to be at the tables with physicians, therapists, all of our interdisciplinary colleagues to lead change together. So, I just want to make sure that we are inclusive as we think about how we improve things and change in the organization. And today, we're going to see a good example of that in one of our presentations.
Thank you.
That's it. Just had to throw in my 2 cents.
All right. So with that, we will have our first presenter, Marissa Hilary. And she's presenting on utilizing structured post-discharge phone calls and telehealth to prevent 30-day readmissions in the cardiac surgery patient population. Marissa?
Okay, hi, my name is Marissa Halyari, and I'm one of the lead nurses here in 7 West Cardiac and Thoracic Surgical Unit. I'm here to present to you one of the many projects that 7 West had accomplished during this year's EBP conference. And the title of our project is Utilizing Telehealth and Structured Post-Discharge Phone Calls to Prevent 30-Day Readmissions in the Cardiac Surgery Patient Population. In this project, I have 4 other very important people who had contributed or have been involved in making this project a success. I have Matt Elasin, one of our telehealth coordinators. I have Michelle Nguyen, who is our cardiac surgery NP, and of course our managers, assistant managers Sherry Neal and Renee Appleby. Before I begin, I just want to let you know that I don't have any relevant financial relationship with commercial interest in this project to whatever we use in this project. So how did we go about with this project? Oops. Okay. So coronary artery bypass graft surgery, which is CABG, is a frequently performed cardiac surgical procedure. With the advancement of technology and changes in healthcare, there's shorter lengths of stays for these surgical patients. So therefore, we have fewer opportunities to give meaningful discharge education. Based on Society of Thoracic Surgery database, UCLA cardiac surgery has 16% readmission rate. And we know that for a fact, preventable hospital readmissions are getting costly. And in fact, in 2 years, Medicare will decrease furthermore the reimbursements for readmissions. And lastly, knowing UCLA best in the West, number 5 in the nation, achieving high HCAP scores, and future magnet redesignation, we don't want any negative impact in our patient satisfaction and outcome. Oops. Wow. One more. Is that the one? Okay. So the purpose of our project, or our EBP question, will be, will a telehealth program that includes structured discharge phone encounters and telemonitoring reduce 30-day readmissions in the CABG patient population? So to answer that question, 7 West nurses in CT surgery NPs designed a structured post-discharge telehealth surveillance program. With this, we also standardized our patient questionnaire, which is now incorporated into Care Connect. And so every encounter, every discharge phone calls or video conferencing, it's always documented now in Care Connect so that our team knows what's going on to patients and so that they could see the progress of what we're doing. We also did an informal tool to screen patients for risk for readmissions. So for low-risk patients, we provide them 4 or more structured discharge phone calls or telemonitoring, video conferencing, and for this encounters, we use WebEx application. And lastly, for high-risk patients, we enroll them to Vivify, which is a 30-day telemonitoring. I brought the box with me, and we provide a kit upon discharge. It is a Bluetooth-enabled device with a blood pressure monitor, a pulse oximeter, a weighing scale, and a tablet. How it works is that the team receive message alerts through their email. Once they receive the message alerts through their email, we access the patient data through a secure web portal. And then from there, the nurse or the nurse practitioner will then do early interventions for this patient. An example would be like when they answer a question in our discharge phone call, like they said they're short of breath. What happens is that we call them to reassess or further assess the patient. And if they say, and if we see that there's a weight gain, then we further do, it's either patient education or we call the nurse practitioner. They might add additional Lasix dose, or they might just come for early visits for these patients. So as you can see, the majority of our patient interventions were medication administration, patient education, home health, earlier clinic visits, treating heart rhythms, wound check, and pain control. As a result, we have decreased our readmission rate from 16% down to 7.4%, which is almost 50%. And we also included some of our valve patients, and we have decreased readmission rates as well. So in conclusion, early intervention, early detection of common surgical complication leads to early nurse and NP intervention, and early interventions such as medical management, patient education, earlier clinic visits, and home health communication are positively impacting readmission rates. And lastly, utilizing telehealth and structured discharge phone, video, RN, and NP encounters reduce 30-day readmissions in the cardiac surgery patient population. Just a final note. I know this has been a win-win situation for all of us. For the hospital, we decreased the readmission rate. For patients, of course, we have helped them in the continuum of care from admission to discharge. But I think for me, personally, I have been inspired, and it's just so rewarding with this project, because I not just help these fragile patients continue their care at home, but also I help them in educating, coaching, counseling. It's not just the patient, it's the entire family sometimes. And you could hear it from their voice, from the words that they say, from the gestures when we do the tablet, and for how grateful they are. And you guys should be very proud about the care, the best care that we give here at UCLA. Thank you.
Thank you very much, Melissa. Next, we have Amy Levine-Dickman, who will be presenting on her work creating a sensory garden in an inpatient psychiatric setting, improving the mood and anxiety of mental health patients. Amy?
Oops. Hello. I'm Amy Levine-Dickman, and I'm an occupational therapist, and there's several in the room today with me. And this project was started on 4 East, which is the adult inpatient psych unit at Resnick. You can see on this first slide a before picture of our planter, which is soil. Actually, there was a before, which was 2 dead shrubs that we're upset we didn't get a picture of. But then the garden picture is when we first planted the garden. And our next presentation, we're going to have another picture of how it has grown. So do I press this or this? This? So here's our team, short 2 people, but when we were presenting at the conference here up campus, none of us from the team have any financial relationship with any commercial interests talked about in this presentation. What's great about this team is there's 3 nurses, 2 OTs, 1 mental health practitioner, and 2 social workers that make up our team of 8, even though you just see 6. So the background where this came from was actually from the patient satisfaction surveys that UCLA put out when the UPC Council on 4 East was reviewing the surveys. There were a lot of patients that asked for more activities, more structured things happening out on our deck. So that was really good news to us, because we've actually been asking to have a patient garden ever since we moved to the new hospital. So anybody who's from back when we were across the street know on 4 West we had this huge deck. And an OT many years ago started a garden with just potted plants. And unfortunately, we weren't able to transport it over. So we were just thrilled when UPC got behind this, and then Pat got behind it. So we, bless you. And really nursing got behind it. So we're very thankful. We divided up, our team of 8 divided up with different activities to go and research. So we did a lit review, and what we found was there wasn't actually anything from inpatient psych, but there was many research that had been done with mental health, mainly community programs, working in the community with people with mental health, and they were all positive. You know, it's always gardening leads to improved mood, leads to less depression, leads to better recovery with addiction. So there was all good signs. So what we did next was we did an A4. Since we already had the problem identified, we didn't have to go to an A3. We went to an A4, which I'd like you to know is quite simple to do. You go right on the web and at UCLA, and there's a form for it. It has 4 questions, and you fill it out. So again, we divided up as a group, and we worked on that. We got the wording the way we wanted it. We put it in, and we got approval. We pulled from recovery model. It's very important on 4 East that we keep in mind that this is towards giving hope to our patients, helping them stay in recovery long after they are here. And we developed a very specific group structure so that anyone on the unit, actually, any of the staff can run this group. It can be run by social work. It can be run by nurses, OT. What we like is it's done as a team. We have 2 people at a time run the group. So sometimes it's 2 OTs, sometimes it's OT and a nurse. And it's structured so that you know exactly what to do. The group starts out in the day room with going around, patients introducing each other and what they like about gardening or what they'd like to know about gardening. We then talk about our garden and what it needs the day that we're doing the group. Oftentimes the soil needs to be turned, the plants need to be watered, sometimes we do deadheading. So there's a discussion on what these different tasks are and what people think they might want to do. And we always tell people it's really okay if you don't want to garden. We have art supplies as well we bring out. So we bring out watercolor supplies, colored pencils, pastels, paper, and then we all move out to the garden, and it's usually a group of about 7, 8, 9 patients. And they garden with us, or they do paintings. And before and after the group, we do a self-rating log. Oops. A self-rating log that has really shown great results. So on our poster presentation, we just had initial results that just showed the first 4 weeks of having run the group. Now we're getting ready to take the presentation to APNA in October in Orlando, and also to Copenhagen in October for a conference on reducing violence in psychiatric settings. So we're putting together new data that still shows this great, this is just pre and post. What's your mood before the group? What's your mood after the group? We're also pulling data from the staff to find out their response to what they've noticed on the milieu with these groups running, and that's all looking really good. And so in conclusion, this is a very cost-effective group as well. It cost us around $350 to get it going and keep it running. Might cost a little bit more on the other decks that we're hoping to move it onto, because those decks don't have a planter yet. So it might be double, actually, the cost for that one. But, you know, somewhere in $500 to $600 probably. And the collaboration, that's been one of the best things from this project, is how well all the disciplines on the floor have worked together to make it happen and keep it rolling. And we continue to get great support from nursing. We need a new plant or whatever, you know, again, it's very affordable. A few bucks here, a few bucks there. And the most exciting thing for me was the very first day we put the garden in. We had the patients out planting with us, and we were able to bring 2 patients into the group that had not been able to be in groups for over a month because of their psychotic symptoms. And they still had psychotic symptoms. They weren't gone. But they came out to the garden and were totally involved, digging soil, planting plants, watering plants, and having normal conversation with us across the garden. So it's, you know, was just wonderful to see that act of doing, you know, in the soil is really beneficial for all. And our exciting news is we're now looking to get IRB approval and turn it into a full research project. Thank you.
Thank you, Amy. Our next presenter comes to us from Hoag Memorial Hospital. Karen Harold is presenting her work on the development of a high-risk breast cancer screening program, lessons from a pilot study. Karen?
Hi, everyone. So, like she said, my name is Karen Harold. I'm here from Newport Beach, California. And just a little bit of a background. Well, first, actually, let me tell you, I have no disclosures, no relevant financial relationships to let you all know about. I started working at Hoag Hospital a little bit over a year ago, and I was hired to start a high-risk breast cancer screening program. And really the background for this program was that according to the literature that you access, we know that Orange County has about the second highest breast cancer rate in the United States, really, really high. So second to Marin County. Like I say, there are some depending on the literature, but we know it has a really high breast cancer rate. We treat about 700 breast cancer patients a year at Hoag, and it's a relatively small community hospital compared to UCLA. So to start the program, we wanted to roll the program out in October of 2014, but to inform the rollout of the program, I thought, we have to conduct a pilot study to really figure out where we're going and what we're finding. And so I sort of based the early part of developing the pilot on the notion that when women are aware of their increased breast cancer rate, that they will become activated to do things that they are told to do to decrease their breast cancer rate. And so what I did was I used the NCCN guidelines to develop evidence-based recommendations for patients that are at increased risk of breast cancer. And I enrolled employees at Hoag Hospital who are between the ages of 35 and 55. I had some exclusion criteria, so the patient could not have been diagnosed with breast cancer previously or ovarian cancer, or they couldn't be being followed by an oncologist. And so we had about 297 employees self-enroll. And we did have a little bit of an incentive for our participants to enroll, which was really helpful, $25 to enroll. And what I had them do was go online and take the Gale risk assessment model. I don't know if you're all familiar with that, but it's a risk assessment by the National Cancer Institute, and it's sort of a quick and dirty, if you will, risk assessment for breast cancer. There are about 10 questions. And so according to NCCN, anyone with a 5-year risk of greater than 1.67% is deemed elevated risk, and I used that threshold to determine if someone was an increased risk or not. And once the participant was deemed to be at elevated risk, I then reached out to that participant and talked to them about what they could do to reduce their risk. And what was really startling was that, and I sort of intuited this in the beginning, was that most of these patients had no idea that they were at increased risk, and a lot of their physicians had no idea that they were at increased risk. So maybe their mom was diagnosed with breast cancer at 32 and died at 34. No one had ever talked to them about genetic counseling or testing or any sort of chemo prevention or anything like that. So it was really exciting for me to be able to engage these women and really give them the tools to decrease their risk of developing breast cancer. So fortunately, I was able to invite people to take a 90-day post-program survey. And you'll see here 140 of the women actually took that survey. And what we found, which wasn't surprising, was that the demographics at Hoag Hospital were pretty skewed according to the national average. But again, that wasn't surprising to us. Across the United States, we know that about 12% of women have an increased risk of developing breast cancer. We found that our employees had about a 14%. We actually found that the median age of people that enrolled was about 45.2 years. 54% of our participants were highly educated. So again, these were employees at Hoag. And we actually found that they had a median annual income of about $100,000. And what we found was that sort of what I thought was true, that when women were told about their increased risk, they actually did want to become educated, and they did partner with me to talk to me about things that they could do to reduce their risk. And so we went through all the clinical things and lifestyle things that they could do to reduce their risk. And then I also sent those recommendations to their clinicians as well. And so, as I said, the important takeaway was that most of the women who were found to be at elevated risk of developing breast cancer did choose to take additional steps. And we've subsequently rolled this program out to all Hoag sites, and have actually found that about 54% of women that are at elevated risk are choosing to take clinician recommendations. And so I'm partnering with them and then reaching out to their physicians and letting them know about their patients' increased risk as well. That's it. Thank you.
Thank you, Karen. Our next presenter is Lori Rayan, who is presenting her work, Incidence and Risk Factors for Nutritional Deficiencies in Children with Intestinal Failure Receiving Home Parenteral Nutrition.
Thank you, and thanks for the opportunity to share the work. This work was a collaboration between my physician colleagues in the Department of Pediatric GI and Nutrition, and also a couple of students at the David Geffen School of Medicine who were mentored by our faculty. So it was another, I think, very fruitful collaboration. None of the authors have any relevant financial relationships with commercial interests. Children with intestinal failure who require chronic parenteral nutrition are at risk for nutritional deficiencies. Nutritional deficiencies can arise despite routine parenteral supplementation as a result of a multitude of factors. It can be inadequate oral intake and poor absorption, increased GI tract and nutritional losses, chronic illness, and in the last 5 years, shortages in the pharmaceutical injury have had a major impact on our ability to deliver appropriate supplementation to our patient population. There have been shortages of pretty much every parenteral component except sterile water. There is a paucity of contemporary data describing nutritional deficiencies in children with intestinal failure, and our aim was to describe the incidence and risk factors associated with micronutrient deficiencies in children with intestinal failure on home parenteral nutrition, specifically looking at vitamin D, iron, zinc, selenium, and copper. And the implications for this is deficiencies of these elements can result in everything from osteopenia to cardiomyopathy to impact wound healing, growth, and a multitude of other things. Okay, the method slide is really, really tiny because of the slide restriction, but basically this was a 3.5-year IRB approved retrospective study of intestinal failure patients followed at UCLA. The exclusion criteria were that they had to be less than 18 years of age, on parenteral nutrition for greater than 6 months, and have at least one serum level of the 5 micronutrients checked during that time period. All patients received intravenous pediatric multivitamin on a daily basis and had intravenous trace elements provided based on our standard dosing guidelines. And all the markers were measured as a part of routine clinical care. The deficiency cutoff for deficiency levels are listed there. And statistical analysis were included chi-square, Fisher's exact and t-test, as well as stepwise multivariable logistic regression. So in terms of results, our patient population was pretty much evenly distributed between males and females. The majority of the patients suffered from short bowel syndrome from a variety of etiologies. The majority of the patients relied on less than 25% of their calories from enteral nutrition, meaning that the majority of their calories were parenteral. And the ethnic distribution of our population is also shown up there, with the majority of our population being of Hispanic background. In terms of our results, the majority of our patients had all 5 nutritional markers checked at least once during the study period, and these patients had an average of 2.5 deficiencies noted each. Secondary analysis that we did to look at risk factors for having multiple deficiencies did not show any specific trends, but multiple deficiencies, which was defined as greater than 3 deficiencies, were noted in 59% of the patients. So what we found was, number one, what we found was we thought we were doing a really good job and found out we weren't doing as great a job as we thought we were doing. And so our summary is, despite routine parenteral nutrition supplementation, nutritional deficiencies are extremely common in children on chronic parenteral nutrition. 86% of the population have greater than 1 deficiency, 59% had greater than 3 deficiencies. Vitamin D deficiency was the most common deficiency noted, and this is particularly troubling in this population because there's not a good intravenous supplementation, so we're relying on an unreliable GI tract for a lot of our supplementation. Anemia is an iron deficiency are also extremely common. And our work basically emphasizes the importance of regular surveillance for nutritional deficiencies at a minimum, in our practices now, that on a minimum on a quarterly basis we are looking at these levels. And then again looking closely at additional parenteral and enteral supplementation when indicated, which has been, again, especially challenging in light of national shortages. Limitations of this work, that is, it's a single center retrospective study. There's a limited number of patients. There are varying reference ranges for nutritional deficiencies. Not all of our labs were checked through our lab. And because our patients are vendored through different outpatient pharmacies, there was varying impacts of the national shortages on availability of the supplements. Thank you.
Thank you. Our final presenter is Anila Ladak, and she is presenting her work improving care of hospitalized elders through niche program.
Hi, good afternoon. So my name is Anila Ladak. I'm the CNS for Geriatrics over at Santa Monica. And in this presentation, I also actually have Valerie Yo, who's not here, but we worked on it together. And we have a few other bedside nurses who are helping us with niche program. So, okay, so just a disclosure, no relevant financial relationship with commercial interest. Just to tell you a little bit background, so as we know, elder population is growing. That's something we all know, nothing new. But they do get sick, they do get hospitalized, and how do we better care for them? So just to give you just a little bit of background, just some numbers. Comprising 37% of hospital discharges and 43% of hospital days, elders are prone to geriatric syndrome. So there's a huge number. We take care of a lot of elders in the hospital. And geriatric syndromes are, if you don't know, falls, confusion, pressure ulcers, adverse medication events, urinary incontinence, pain issues, and challenging psychosocial issues. So they get sick, they come to the hospital, and they also have all other issues going on that we need to take care of. Niche program. So what is niche? It's a program of the Hartford Institute of the New York University College of Nursing, and it's the only geriatric program that we know of, and it's the leading nurse-driven program designed to help hospitals improve the care of inpatient elders. And actually, they're going out to communities and SNFs as well as nursing homes. So I should take that inpatient word out. Okay, so why did we adopt niche, or why did we get niche designated is the right word. So 5 North Wing Geriatric Unit, we wanted to, of course, improve care of our elders. Valerie had heard of the niche program, so we explored it, and we found it very, very useful to be able to take care of the geriatric patient. So some of the things, since because of the limited time, I'll just jump to the things that we have done, and there are a lot more. So just a summary of some of the things. So when we adopted the program in 2012, some of us went through the leadership training and got designated for niche. So the whole, actually the Santa Monica Hospital is niche designated. Then they have a assessment or kind of a survey to assess nurses' knowledge and attitude in caring for older patients, which is called GAP. So we administered that. We actually took that GAP survey, just the geriatric unit to start with. And then actually December of 2014, we took the survey again, and this time we involved the adult units, all the adult units in Santa Monica. The comparison, and I'll give you the comparison later, of the geriatric unit. So other things, number 2 is niche care delivery model. So niche has two basic models. One is called GRN, Geriatric Resource Nurse, and the other is ACE unit, Adult Care of Adult Unit. So GRN is getting our nurses prepared to giving them knowledge and experience to better care of geriatric patients. Niche has a very interactive, very informative website, and they have a lot of resources. They have, for example, programs on geriatric syndrome, falls, pressure ulcers, that nurses can take in their own time and get more informed. They have monthly webinars, and they also archive those webinars that you can access anytime. A lot of resources for actually patients and families as well. You can interact, you can get connected with other other niche institution, and see what they are doing and kind of learn from them. So a lot of programs, a lot of things that are happening on a niche umbrella, you have access to all of those things. So we had our nurses go through the niche program, GRN program, and they took online modules to get educated. And the ACE unit, we're lucky actually over here at UCLA that we do have a designated geriatric unit, and we already have a lot of things that niche kind of wants ACE unit to have. Okay, number 3, we're working on a lot of different projects which are evidence-based, and we learned about them through niche. So I won't be able to go through in details, but I'll just give you an example of the dining companion. We actually train our volunteers to help us feed our patients who are, slow eaters, but kind of safe to eat. So we have this program ongoing. And I'll talk about the last one, UCLA Companion Program. We just got some donation, and then we're working on this companion care program, which kind of combines all of those other things, where we're going to be training volunteers to help us feed, help us spend time with our patients, utilize activity card, help with mobility, and a lot of other things. Okay, just running through quickly, talking about the GAP survey. So you can see the comparison. Before, the knowledge was 4.7, and it improved to 6.9 after taking GRN courses. And UCLA has achieved the senior-friendly status, which is the second highest status for niche. In conclusion, our goal is to continue to improve the quality of care of our elders by increasing staff knowledge and of geriatric issues and their competency. Actually, the goal is to advance this program to other units. So like I said, we just did the GAP survey, and we're going to actually bring this program to one of the other med-surg unit, and eventually when all the Santa Monica units are kind of niche designated, we'll bring it to Ronald Reagan as well. Thank you.
Next slide. All right, thank you so much to all the presenters. And now, I'm sure those were all wonderful projects, but I'm sure they were not without their challenges. As we all know, change is hard, and it takes a lot of perseverance. So I'd like for you to share some of the challenges that you faced, and possibly how you overcame them. So who wants to take a stab at their first panel question? Okay.
So one of my big problems was
Is that on?
was physician buy-in. So at Hoag Hospital, I think we only have about 5 nurse practitioners in the whole hospital. So physicians aren't used to collaborating with nurses, and so that was a big problem. So what I did was I went to the monthly meetings, OBGYN meetings, primary care meetings, and then went out to the offices, and so gave lectures to the physicians about the program, you know, what they would expect from me, what I would be telling their patients, really talk to them about risk assessment for hereditary cancer syndromes, and it really helped a lot. It's really helped sort of assuage their doubts and their fears, and they're finding the program really helpful now, which is great.
I would say for myself and for my collaborators, at least the faculty collaborators, finding time to do the project, even though it was a relatively straightforward project, there still is time involved. And I think, and I cannot take credit for the idea of bringing the med students into the mix, which was but the ability to they really provided the manpower in terms of the data collection, and it afforded them, you know, an opportunity to be mentored. And one of our med students presented this at a national conference, which was a wonderful opportunity for her as well. So I think time, and then finding ways to make the time or engage the time.
I think for our project too, because it's time, because what we do is that we spend 6 to 8 hours doing discharge callbacks or patient encounters, and this is just during the weekdays. Weekends, we also do 1 to 3 hours of doing the video conferencing with a tablet. And one minor thing is about our technology, because we send out pulse oximeters to patients, and sometimes they run out of batteries. And being elderly and the complexity of their situation, but we were able to resolve that, because now we send our kits with extra batteries, and then when we tell them on how to use the equipment, we always show them now how to change the batteries.
I would say for our project, it's a continuous project. Basically, it's staff buy-in. It's a culture change, and it's like it's work going on and on. So, which we cannot just do by ourselves. Staff has to be involved. There's so many projects going on. So I would say staff buy-in was a challenge for us. And the other one is completing priorities. Because we're doing all this with our regular work that we're doing.
How did you get the staff buy-in?
We always try to stay positive and talk about it all the time. So staff meetings and huddles, do a lot of presentations, keep them updated, posted flyers for webinars and stuff. So always keep talking about it.
Great.
I don't think we really had many challenges, but hearing time, I would say time is always a challenge for everyone. Find the time that it takes to get it going, but we had such passion from our team behind it, it just moved fast.
So what about positives? What was the most rewarding aspect of your projects?
For me, the most rewarding was what I shared with you about having patients that weren't able to participate before really be involved in groups, and then just having this interdisciplinary team with support from all departments has been really satisfying, and I would say it's what's keeping me at UCLA right now.
I think I said already the most rewarding part of my project, because we not only decrease readmission rate for the hospital, not only we provide good care for these patients, it's also the way I've been very passionate to the point that I miss calling patients when I'm home. That's how it is. And I say that passionately with my telehealth coordinator, because that's what it is. Because we're nurses, we care for patients. It's our job. It's a natural thing to do. But I didn't have problems with buy-ins too, because in fact, preventing readmissions is actually a focus of the hospital, and it's been very relevant. It's not just for surgical patients, but all unit as well. So I have the support of my managers. We have quality who introduce the kids. We have performance excellence, which is also part of it. And I've heard that telemonitoring is now also in other departments as well. So I didn't have that.
I think for our project, the fact it's been very well received in the parenteral nutrition community, and we've gotten feedback from other centers and our colleagues across the country about the usefulness of the work. So feeling like we've made a contribution or raised a flag about the issue. And then also the fact that it's helped us improve our practice. It's kind of shined a light on what we can do to do better for our patients.
And for me, I kind of alluded to it earlier, but I think the most rewarding thing is to really be able to work with the patients and really talk to them about what they can do to reduce their risk. So when I first talk to patients, they're really scared and freaked out, and they think they're going to get breast cancer, and they have absolutely no idea what to do to reduce their risk. And as I told you, in many cases, no one's ever talked to them about the fact that they're at increased risk. So I'm able to really give them tools and, also give them reassurance that I'll always be there if they want to reach out to me or have questions or follow up. It's just been really, really rewarding to empower women, really.
All right, I think we have time for one or two questions from the audience. Rose.
So this question is to Marissa. And you identified patient education as one of the issues that came up second from the top on your interviews with your patients. Is there anything that you've done since you've gotten this data back in terms of changing the content that's taught patients, the structure?
What you want to hear from me. Since you're leading the CNS. Actually, a lot of our new grads are doing Teach Back now for our Healing Heart Handbook. So that's one thing, because I think it's because of the shorter length of stay, we don't have enough time to educate our patients. Mm-hmm. So right now we're dealing with projects from our Healing Heart Handbook, we're trying to do it face by face in teaching patients and with teach back process. So that way, because not a lot of our patients are ready to take in all the information. So it's just nice to have, like, in our questionnaire, it was divided into groups wherein we know what are the reasons why patients be admitted to the hospital. So we have specific questions on every reason why they might come back to the hospital. So the education part is always there. Because even though we educate our patients, like, for example, you have to take a shower. They didn't know, like, what is taking a shower? Is it like sponge bath? It's also part of their educational attainment. Because a lot of times they are scared of washing their incision. They're scared of wetting it. So they have part of their culture that anything that you will wet because it's a wound, you can't do it. So it's just like a process of learning.
Okay. All right. Any questions from Santa Monica?
Hi, there's just one quick question. This is Pamela Miller. First of all, I'd like to congratulate all the presenters. Wonderful job. We thank you for presenting or sharing your work with us. My question is, I would appreciate if you could share your dissemination plans as it relates to local, national, and international conferences, or if you have plans for publishing your work. Be interested to hear about it.
Well, we started by submitting abstracts to the two conferences I mentioned. So we're going to Copenhagen and to Orlando, Florida, to a national conference there. We won't be publishing this, but we do hope, as I said, to do a full-on research project, and that for sure will be published. The other thing that we plan to do with this is put it out throughout NPH. So right now we're the adult unit. We hope to have a guardian on the geriatric unit and also on the adolescent child unit in the near future.
I think in our unit, there's a possibility of doing it, but I'm not sure, maybe in the future. Because right now, it's not only our unit who's doing telehealth, I think other units as well. Mm-hmm. But we might.
We have presented the work at our National Parental Nutrition meeting, and there are plans, time allowing, to write it up.
So I wrote this study up in an abstract form and submitted it to NCCN, which is the National Comprehensive Cancer Society, and actually presented it in March at their annual meeting. And then they published it in their JNCCN journal. And I'm hoping now that the formal program is rolled out to sort of compare the pilot with the formal program and, just see how the findings compare, and hopefully just encourage centers throughout the United States to, adopt programs like this. And you already have one at UCLA, by the way. So.
Right.
We're planning to submit an abstract to annual niche conference, which is going to be held next year in Chicago, I believe April. Other way to disseminate our work is we share definitely our work with other units. For example, we did the geriatric simulation training for our staff, and now we're doing it for at least for all the new grads for other units each time they come. And our UMO program, which is our mobility program, which stands for Mobilizing Older Adult Vigilantly Every Day, is actually being adopted. It's the system-wide. And Alan Wilson is leading this committee where we're trying to merge all the different mobility policies together to make it one. and we're adopting this name as UMOVE, and we're going to disseminate to all the system and all the good practices that we've done on our unit. Hopefully, everybody will be doing that on their units.
Great. Well, thank you so much to all of our presenters. I think they deserve a big round of applause.